It's been a pleasure, by the way, to work with people at Waterloo, Dominic in particular. We did a big piece around developing a health informatics curriculum, and Dominic was a Canadian leader in it. And I think some of that work, which is available on the web, called Pointing the Way, Competencies and Curricula in Health Informatics, is available to everyone. And I think that's provided some guidance for those of us at other schools who've been developing health informatics curricula. We have a graduate program in health informatics now as a collaboration between the faculties of medicine and computer science and management. And for the introduction, I think you've heard the important part of the rest of the story, that basically in Canada the health system is unmanageable, I think, because people don't know what works, what doesn't work. We can't identify which activities are superfluous to results, which ones are pertinent, and which ones are harmful, because by and large we don't bother to measure results. I'll say a bit about how we do capture performance information in healthcare. And I think it's quite surprising that we don't bother to capture results, because we make the investment in the infrastructure that's necessary for results measurement. The more things change, the more they remain the same. This slide could have gotten into very, very tiny font, in very, very tiny print. When Less is Better, which was commissioned by the federal, provincial, territorial deputy ministers, said we need to measure outcomes. Our paper, Public Health State Secret, the National Forum on Health, the Romanow Report, definitely not the Romanow Report, Mazankowski, Kirby, everyone says and agrees that we need to measure results, but somehow we don't bother to do it. HealNet, which was one of the National Centers of Excellence, their comment was, many bad decisions about healthcare are made every day in Canada because decision makers lack the right information at the right time in the right place. These bad decisions can cost the country millions of dollars and rob Canadians of the health care they need and deserve. It's kind of still topical, given that we just heard, and I can't decipher from the media reports whether we're getting $3 billion or $9 billion into health care. And I stopped by one of the constituency offices on a run earlier this morning, and they weren't sure whether this was new money or old money being reported again and again. But it's still, it's more than pocket change going into healthcare, and some people have said that it's a black hole, and the people who said it seem to be not restricted to either the ideological left or right or center, but you hear that from a diverse range of people. The AuditorGeneral, and this was an early comment, this is what he said when he commented on our paper, Operating in the Dark. He said, in relation to the Canada Health Act, I observed that Health Canada does not have the information it needs to effectively monitor and report on compliance. So within these areas of federal responsibility, it's clear that better information is required. The Canada Health Act has 5 items: universality, portability, comprehensiveness, accessibility. And I won't go into each of those, but we know that everybody doesn't have universal access. It's not portable. The menu of services around the country is different. Comprehensiveness, people who are poor and even the middle class often aren't able to get the drug treatments that they need. And access is sometimes limited because waiting lines for certain procedures are lengthy, and even for some treatments that are life-saving. Public administration seems to be the dimension that's mainly enforced by public administrators. And some people say, duh, well, what would you expect? But that's another story. And what Romanow and others have said is that in the Canada Health Act, there's no actual requirement that the quality of care that people get be terrific. There are no statements about what kind of results we should expect. The deputy ministers in 1994 made this commitment when they unanimously committed to and endorsed the paper, When Less is Better. They said timely access must be guaranteed and information about waiting times made public. They also said the quality of care will be ensured by ongoing monitoring and publication of outcomes as changes are implemented. It's hard to believe, but in Canada today, no deputy minister or minister of health can tell you how many people are waiting for care, what they're waiting for, how long they've waited, and what are the consequences of waiting. And we certainly haven't seen much information about how many people get better or worse. And I'll say a bit in a few minutes about some of the opportunities that we're missing to actually capture this information. It's interesting that an article in the British Medical Journal this month reported that Health Canada was awarded the Canadian Association of Journalists' 4th Annual Code of Silence Award. They said that Health Canada is the most secretive government department in Canada. And the commendation said they show remarkable zeal in suppressing information and concealing vital data, which is kind of interesting. If you think about efficiency, we're all talking about having a system that's effective and efficient. So efficiency is really cost for a benefit. You can't say whether a system is efficient or not unless you know what the benefits are. And often in healthcare we use cost as a proxy for efficiency, as you'll hear in a few moments. I'm on a social determinants of health listserv, and one of the members of the listserv spoke about 2 types of efficiency. Pareto efficiency, and he remarked that an outcome is more efficient if at least one person is better off and nobody is made worse off. And another type of efficiency, Calder-Hicks efficiency, that says a more efficient outcome can leave some people worse off. And the example they gave is putting airports in cities. If you have an airport in a city, the noise disturbs some people, but presumably the benefit to everyone outweighs the disadvantage to the few. In healthcare, some people benefit more from government spending, but we know that others are worse off. We heard the AIR report in the last few days, which said that a number of people who receive care have adverse reactions to the care they receive. So in deciding whether the system is efficient and whether we should spend more money on healthcare, we have to know whether the benefits outweigh the harms. And for both types of efficiency, measuring results is essential. How many people are better off from the treatment they get? How much better off are they? Kirby, when we presented to Kirby's committee, it was a very, very odd experience. In the middle of my presentation, he started to laugh. And I sort of stopped my talk and said, "You're laughing, what's so funny?" And he'd leaned over and spoken to his research associate. He said, "Well, I was just saying, you've told me that nobody measures access and nobody measures results. And we heard earlier that nobody knows what anything costs. So the question," he asked, is, "Tell me, how do you manage healthcare in Canada?" And I said, "The good news for me is that the person after me was one of the senior people in the School of Health Services Administration. I told him that he would tell you. But obviously, it's not possible to manage anything unless you get some measures. And Drucker and others have all said that you can't manage what you don't measure. The corollary, I guess, is, and you'll hear in a moment what I'm talking about, the corollary is that if you don't have to manage it, why measure it? And in Canada, because of some peculiarities in our health system, we really don't have to manage it or measure it. Sad to say. So how do we capture information? This is a copy of a note that's sent out on a regular basis by the medical insurance group in Nova Scotia. And essentially what they do is they send a note to patients. And I think they do this in Ontario and other provinces as well. They randomly select office visits, and they send a note to the patient and say, "On this and this day, did you see this doctor?" In this case, in February, the price of an office visit was $20.24. What happens usually, people call and say, "Doctor, my problem was more important than that. How come I only saw you for 3 minutes and you charged $20? So I think it's sort of strange. So they ask if you saw the doctor. In a normal business or a normal operation, somebody would say, "How long did you wait for care? Did you benefit from the care?" We have a structure in place to send the requests for information out. We have a structure in place to get the information back. We just don't bother to ask the important questions. For patients, the purpose of care is to improve comfort, to improve function, and to improve life expectancy. So when patients go in to see a doctor or nurse or anyone else in the health system, they don't really care about the fancy words that we use. They come in and they say, doctor or nurse or physiotherapist or whoever they're seeing, they say, either I have an ache or a pain, can you help me? Or I can't do something, can you help me do it? Or maybe they have a lump in their neck or they have a lesion on their skin. They say, is this something that will predict that I'm likely to die more quickly? The other useful service that we provide in healthcare is information. And if you take the example of someone who goes into a doctor's office and says, I have chest pain, but the chest pain really isn't too bad, I don't mind it, but I only mind it if it's a sign that I have heart disease. So we go through a set of investigations and we tell them it's not heart disease, it's a muscle strain. And they say, great, I'll continue with my activities. I don't care if my comfort improves because it's not that uncomfortable, and I prefer not to take medications anyway. So how much do we spend in Canada getting information now? Why is it such a problem that none of the political parties who talk to you can tell you how many more people will be better from the money that they spend on healthcare, how many will be worse, or what the waiting times will be? It's not because we don't pay for information. In Canada, the Canadian Institute for Health Information gets about $95 million every couple of years. Are people familiar with the Canadian Institute for Health Information? Some of you? Some, but not all. So in a moment, I'll go through the process. At the Queen Elizabeth II Hospital in Nova Scotia, it costs about $2 million to abstract charts for 500 beds. I'll tell you about the process in a moment. For Canada as a country, we spend about $700 million going through the charts. The output we get is length of stay by diagnosis and procedure. How long were people in the hospital who had a particular diagnosis or who had a particular procedure? Nobody bothers to say how sick were they when they came into the hospital or how well were they when they left. So we don't know how many people were better or worse off. We don't know if they were subject to error, and we don't know how long they wait. If you think of the headline-making report from Baker and Norton that was in the paper recently and is available on the Canadian Medical Association journal site, their methodology was to get still another set of health record reviewers to go through every chart and say, was there an adverse event or not? When you consider that at the same time as they were doing this, the normal process whereby every single chart goes through a detailed review was carrying on, one has to wonder whether it was redundant and whether we could have used the normal processes. So the way the process works, and I think many people aren't aware of this, if you're admitted to a hospital, those of you with legal training might even find it interesting. When you're admitted to a hospital, when you're discharged from a hospital in Canada, your chart goes down often to the basement of a hospital where there are a set of health record coders. In the Capital District, we have 22 of them for 500 beds. They go through every single page of every chart. They capture the diagnoses. They capture the procedures. They don't ask if they're better or worse. And it's interesting, according to the Canadian Institute for Health Information, which is the major data gathering group in the country, we have more health record administrators in Canada than social workers, which was sort of a surprise even to me when I read it a few weeks ago. The information, after it's collected, is abstracted and sent to the Canadian Institute for Health Information in Ottawa. They have offices, central offices in Ottawa and Toronto. The information goes with actually quite detailed personal information. And ChiH is a not-for-profit, private organization. The board is largely comprised of the deputy ministers of health. The Auditor General said that was concerned because they said that they're not they're not required to report on their activities. So after the review process, the organizations are able to compare length of stay by diagnosis. And many of you will have seen reports, for example, the ones in the Claims magazine come from the ChiH Reports. They do make some adjustments based on the number of diagnostic labels. So they'll say that a patient with pneumonia and diabetes would be expected to have a longer length of stay than a patient with pneumonia alone. But when you think about it, some people with serious pneumonia may be in for a long time, and somebody with pneumonia and diabetes might be going for a walk in the park. There are coding reliability issues. There isn't strong evidence that the coders code the charts in exactly the same way. So when you compare hospitals one with another, it's not clear that you're comparing differences in clinical and administrative behavior or differences in coding behavior. And there's no severity adjustment. This is an example of the type of report you got, and I purposely haven't changed the slide. Essentially what they'll do is they'll take for a service like medicine, they'll take the number of cases there were, they'll get an average length of stay, they'll compare it with the average for the database, and then they'll make a comment that that particular hospital was 1 or 2 or 3 days over the average in Canada for people with similar diagnoses. This was done. We participated in a study. ChiH recently or a few years ago, put in a piece where they started to capture the other diagnoses. So when you adjust for complexity, the number of days over and under actually changes. So the database mean, when you include the other diagnoses, went from 6.1 to 8.3. But you don't know whether that means that the coders are just more, and some of you know the coding process quite intimately. You don't know whether it means that the coders are much better at capturing codes, or whether the doctors and nurses and administrators are admitting healthier people. And then the way funding seems to have been developed in Canada over the last few years, they'll look at a hospital and say in our case, our coders were terrific, so we weren't over. But they'll say, you're over the database average, so we can take away these number of days and you'll be like the database average. And we'll cut beds, cut nurses, cut doctors. There's an interesting piece that Mount Sinai Hospital did. They moved to concurrent coding, where they actually took the coders out of the basement of the hospital, put them on the hospital wards, and what they reported at the coach meetings, I think it was either 2 or 3 years ago, they reported that as a result of changes in coding practice, their hospital got another $9 million. So there are no changes in administrative performance. There was no changes in clinical behavior. There was a big change in coding practice, and the hospital seemed to be much more efficient than it had been before. The British Medical Journal, looking at this type of analysis, made the remark in a paper in 1998, any action prompted by annual league tables would have been equally likely to have been beneficial, detrimental, or irrelevant. So according to them, rather than use these methods that are so expensive, we might as well flip a coin. And the other piece, of course, is that we don't adjust for multiple comparisons. So if you have a hospital that treats hundreds of different diagnoses, it isn't surprising that even if all the hospitals are doing things similar, that some will appear to have a longer length of stay than others just because there's a statistical variation. The AuditorGeneral, who reviewed these performance indicators, made the comment, data used for 7 indicators were drawn from the relevant Canadian Institute for Health Information databases. Both the federal and several provincial Auditors General made these comments about the type of methodology. And these are just the procedures that they used. And their comment about the methodology was that at this time I'm unable to provide an opinion on the accuracy of the data and the adequacy of disclosure on limitations of the data drawn from the discharge abstract hospital morbidity database of ChiH. for the indicators. My inability to provide an opinion is due to a lack of documentation of the ChiH quality assurance process, and because ChiH's 3-year abstraction study, which will provide information on the quality of data, will not be completed for another 2 years. So they said that last year. So now let's go back to what the deputy minister said that they would do. The deputy minister said that every hospital would implement concurrent review. Concurrent review is a process whereby people go through the chart while the patient is in the hospital to capture information. And this is the Mount Sinai story that you've heard already. We set up a project in Nova Scotia several years ago where we said that if deputy ministers and hospital administrators are concerned about length of stay, what's really important is that people be in the hospital appropriately in the right setting for care on each day that they're in the hospital. So people can be in hospital getting either services that are unique to hospital or services that aren't unique to a hospital. If you need unique hospital services, then you have to be in a hospital, regardless of whether your function is normal or diminished. On the other hand, if your function is diminished and you don't need unique services, then you should be in a long-term care home. If your function is normal and you don't need unique services, then you're normal. You should be home. So we said, can you identify on a daily basis whether people are in the right setting for care? And guess what? Lo and behold, of course you could. Because if you couldn't, I wouldn't be here telling you the story. Sad to say. But so this is a graph that was available on the wards of the Halifax Infirmary. It basically said what were the unique services that people were getting, and was available for each patient for the ward as a whole. It was, in this case, they were getting oxygen, IV, observations for vital signs. We said if you needed to have your vital signs observed more than 4 times a day, that you should be in the hospital. And then you could see the proportion of people who are getting unique services and the proportion who are getting non-unique services. And this was later on in the study, so you found that as you gave people prompts, because if you found that a person was in the wrong setting for care, that if you gave them a prompt, people would actually discharge the patient. So rather than use a retrospective method, we were able to use a concurrent real-time methodology. The other thing that's interesting, getting down to outcomes, if you consider the clinical process, when people do clinical medicine, in order to practice, in order to know whether to treat somebody or not, you have to estimate health status. Right? You have to say, is your comfort poor, is your function poor, are you likely to die? Because if you don't know that, then how do you decide whether to treat somebody? So at every encounter with the health system, we estimate health status. And outcomes really are just a change in health status associated with care. So the information today is recorded routinely in doctors' notes, physiotherapists' notes, but not normally collected in a systematic way. So when we did that concurrent review study, we were able to capture from the nursing notes. And some of you may not realize this, and I think this is a terrible tragedy. So those of you who have friends who are nurses may not realize it, but we don't capture nursing information. But the nurse, or do we capture it now? We still don't capture it. You've heard the story before. It's a very strange story. We don't capture, when you consider that somebody in a hospital is often in a hospital because they need nursing care, and we don't bother to capture it. It's strange. But in this study, we're able to use the nursing information on a daily basis to collect information about mental and social functioning and information about physical function. And you can see as the person was treated, their function improved, mental and physical. And what you hope is when you discharge somebody that they'll be better. And I only tell you the story to say that it's possible to capture that information in real time. It's not expensive to do because we actually do it. The only thing we don't do is capture it. And that's an administrative decision, not a clinical one. It's very interesting. How many people in the room have read the reports of the Baker-Norton, of the errors study? Nobody has read it yet? Essentially what they did is they went through a selection of charts. They found that 1 in 13 people admitted to hospital are subject to an adverse outcome that could be preventable. They said this is equivalent to thousands of people dying on a regular basis. They then went on to say that one of the reasons these errors happen is that doctors are reluctant to admit their errors and report them. But isn't it strange that we already have a structure in place where somebody goes through every single page of every single chart and nobody bothers to capture it? It's not the doctors who are hiding the information. It's the administrators may not want to know it. In the strange life and the strange work that I do, I sit on the Medical Society's IT committee. And what's very odd to me and very interesting is that the comments that administrators make about clinicians are exactly the same as the ones that clinicians make about administrators. And then you say, well, do you think anybody wakes up in the morning and wants to do a bad job? And everyone says, no, everybody wants to do a good job. So what Norton and Baker say is healthcare is a risk for adverse results. But it's strange that even in this special study, with physician reviewers going through every chart, no one bothered to ask about the benefits of care. So we know that 1 in 13 people suffered an adverse event, but how many people were better as a result? How many people weren't better? The World Health Organization has a definition of health that isn't very helpful, I think. They say health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So what do you do with that? You can't get any operational or formal measures as a result of that definition. But there are proxy measures that people use. And proxy measures, when you think about it, are less important to patients than direct measures. We had a discussion at lunchtime about cholesterol testing. People don't really care what their cholesterol is when they take drugs to lower cholesterol. They really want to know, are they less likely to die? Right? It's not, they don't care about the cholesterol number. If somebody gets a report back telling them what their hemoglobin number is, they just want to know, what do I have to do in order to feel more functional and more comfortable? So the direct measures are likelihoods of dying, and you can develop predictive models based on lab findings. One of the studies we did was with an American system developed by Metis Groups, where if you take the list of lab reports, the objective signs and lab values, you can develop regression equations that predict likelihood of dying. So if your hemoglobin is 4, you're much more likely to die than if your hemoglobin is 12. If your hemoglobin is 4 and your blood sugar is 38, then you're even more likely to die. And some of you may be saying, well, then you're probably dead already. But so it's possible to measure that. People are interested in measures of fatigue rather than measures of hemoglobin. The ability to walk without pain rather than X-ray evidence of a healed fracture or disc disease. So what are the ways that people measure results? They're unidimensional measures on particular aspects of health. I'll show you some items from the McGill pain questionnaire in a few minutes. There's a Beck depression inventory that looks at some items such as sadness or social isolation and asks people questions like these. Do you feel sad or not sad? And they ask it about a number of dimensions. This is the McGill, this is a variant of the McGill pain questionnaire. But you can see that if you do this on every patient on a regular basis, it might actually paralyze healthcare. Because if somebody comes into the doctor's office and says, I have a serious, severe pain in my leg, if you go through all of these pieces, the number of doctors and nurses we have in the country aren't sufficient. But it's important to do this on at least some sampling basis. So this is an example of a specific, of a one-dimensional piece. Then there are measures that look at overall health. There's a group that are advocating that we collect on a regular basis information from a questionnaire called the SF-36, which is a measure of the overall health of a person. if you consider when a person gets treated for, say, a fracture or gets surgery, it's important to capture not only condition-specific information, but also overall health, because measures of overall health let you know whether you're creating complications or not. So if somebody has surgery for, if somebody has surgery and for a fractured hip and then develops a stroke, you may find that their hip is fine and the surgery was successful. But if you find that large numbers of people are getting complications from the surgery, not related to the specific surgery, but in another system, it's important to know. It's important for informed consent as well. There are disease and condition-specific scores, like asthma quality of life scores. I can go into the details of them, but these are all very widely available. It's just to give you some idea that there are a variety of ways that are relatively simple that people can use in the normal course of care to measure results. There's an example of some of the questions from the Knee Society score. How much pain does a patient have while walking? They also ask questions about stairs, crutches, range of motion. When you think about it, if you have a friend who can't walk, to understand them, or a surgeon, or somebody who goes into a doctor's office and says, I'm limping, they don't really need all of this information. Using pattern recognition, the clinician can understand much of this. So you end up with a paradox that in order to do objective and reliable studies, you have to encourage doctors, nurses, and others to capture large amounts of information. That becomes expensive in terms of time, money, energy. And in fact, some people have said that one of the disadvantages of the electronic health record is that it interferes with pattern recognition. So if somebody comes into my office and is wheezing, short of breath, and going, I know right away that they have asthma, or that there's a good chance they have asthma. If somebody then asks me to put in all of the specific points, it may divert my attention from the fact that they have asthma. And as you look around the room, if you think of your colleagues and your friends, if somebody gave you a description of your friend and described their hair, their ears, their nose, their mouth, their fingers, their clothes, you might not know who they are. But if you said, I just saw Fred Farkle, then you know who they are. There's some outcomes. In the Capital District, we've asked the clinicians when they discharge people as part of a structured discharge summary project, we've asked them to estimate comfort and function at the time of discharge. And these are some reports that the cardiology group has given with regard to function. This is some reports with regard to comfort. And the psychiatry department is doing exactly the same thing. We've asked them to provide some estimate of discharge as to whether people are better or worse. So our Canadians, are we getting what we pay for when we put in all this money into healthcare? 115 billion at least, and probably a lot more. Do we know how many people are benefited or not? We don't, because we don't have information about how many people have improved comfort or function or increased life expectancy. Although we do know that on a daily basis, the health system produces miracles. We just don't know how many miracles. And we don't know whether the harms outweigh the benefits. I believe that the benefits outweigh the harms, but we don't know that for sure. So we need to link activities and results. We need to, if somebody recommends for a patient with a sore ear that they do nothing, we need to know how many of the people who have had no treatment for infected ear, how many go on to get mastoiditis or meningitis. And if we treat them all, we need to know how many of the people who are treated go on to get anaphylactic reactions and serious drug reactions. Without that information, we really can't be sure that what we're doing is right or wrong. And one of the notions that I discussed with your president before the talk was that when I was practicing, I was delivering 100 to 150 babies a year. As a result, I'd have lots of children come in. One of the most common reasons that kids come in at a young age, those of you who are parents probably have been to a doctor's office with a child pulling at his ear and an infection. I didn't know whether I should give them an antibiotic or not. Now, how bizarre is that? So you basically would ask the mother, which do you prefer? Whichever answer she gave was right. So the common practice now is to say, here's a prescription. If it's not better in 2 days, fill the prescription. Use Tylenol in the meantime. But how strange is it that we don't know? Pills, some are beneficial, some are harmful, and some do both. How often? One of the pieces that the Canadian Institute for Health Information has been promoting for many years is that if a woman has a cesarean section for her first birth, that she should have an attempt at a vaginal delivery for subsequent labors. Yet the New England Journal says that there's a 1 in 400 increase in mortality. So you don't know whether a high rate is beneficial or harmful. Is it better to let women, or to encourage women to try to have a vaginal birth after a C-section or not? Without information about what the consequences are to the mothers or babies, it really is impossible to know. And in fact, in the last few years, the tide has changed, where people are saying, well, it's probably more appropriate to encourage people who've had one C-section to have another one, because you reduce the risks to the mother or baby. I'm not an obstetrician or gynecologist, so this isn't meant to take a position on that particular aspect of it. Antidepressant drugs. Antidepressants, as you probably know, are the second most widely prescribed category of drugs in Canada, just after cardiovascular drugs. There are a large number of studies that suggest they're no better than placebo. For those who are interested, you can look at one of the studies is called The Emperor's New Drugs. The other is called Listening for Prozac but Hearing Placebo. And what's really surprising to me, when I look at the drug literature, the advertising for one in particular Effexor, they say there are no studies that have been done longer than 8 weeks. In the prescribing information, they also say it may take several weeks before this drug is effective, which basically means, does that mean you have a 1-week window of opportunity? So, in a sense, shouldn't drug labels be required to indicate the likelihood of benefits and harms? For Effexor, 1 in 1,000 patients have seizures. Shouldn't people be told that? But more importantly, shouldn't we, as a community, insist that we capture theรื่องabout the long and short-term results of the activities we do? So what are the issues? Outcome measures and measuring health status supports clinical care, research, and health services administration. But who benefits the most from outcome measures? If clinicians spend a lot of time documenting in their charts in this very bizarre and peculiar health system we have, it costs them money. So they say, I'm not going to document this carefully and seriously. On the other hand, researchers and administrators really would like to get that information. Who should pay for it? And then how do we decide if the better measures are cost-worthy or not? And our guesstimates, such as we're doing it in the Capital District, are they sufficient? Is it enough to ask people, how do you feel? What's your comfort like using a Likert scale? What's your comfort like? Has it improved or gotten worse? What's your function like? It's interesting that for the project we're doing at the Capital District, as the clinicians become unsatisfied with measures that aren't rigorous, they're beginning to impose on themselves to capture more rigorous and valuable information. So this is, I think, the real challenge. The real challenge doesn't have to do with clinical care or any other part of it. I think the real challenge is that healthcare is an unregulated monopoly. How is it that after at least 10 years of the deputy ministers and everyone else saying we need to measure outcomes, we don't measure outcomes? And the argument that some of us have made is that healthcare is an unregulated monopoly because the regulator and the monopolist are the same. Kirby, in picking up on some of the work that we did in Public Health State Secret, said that it's really vital for a successful system to separate government's role as an insurer from their role as an administrator, regulator, and evaluator. Because now you have a system where governments essentially are evaluating and regulating themselves. If the waiting lists become too long and unsuitable, and government slaps a hand, governments themselves say, ouch. And then the other piece is you can't manage what you don't measure. But if management isn't necessary because you're an unregulated monopoly, then neither is measurement. I gave a talk a few years ago, and somebody from a vice president, a senior person at Xerox was there. They reported that in 1980, when the patent for copiers was no longer valid and other people could make copiers, they found that they could go on the street and buy a copier for the same amount that it cost them to make it. They reported that while they were a monopoly, if a company came to them and said, look, there's 6 blotches on our copy, that Xerox would tell their customer, well, that's within our quality guidelines, it's acceptable. They said as soon as there was competition, they changed their tune, and they dramatically reduced their costs because otherwise they would have had to leave business. We have activity-based incentives for care. So there's really very little incentive either for institutions or individual doctors to identify activities that are superfluous. Grace Patterson, who works with me, used a method called rough sets that allows you to link activities and results, to learn which activities contribute to a result and which aren't valuable at all. But unless you can capture results in the first place, it can't happen. The other thing is patients can participate. Now as we develop web-based tools and technologies, there's no reason that patients themselves can't get on the web, can't get into their own records and provide the information that people need to know whether somebody's health is changing or not. And I guess one role some of us feel for government is to insist on appropriate labeling, to insist that when drugs are dispensed, that they come with some label that says, these are the likelihood of beneficial outcomes, and these are the likelihood of harms. After all, we do it for foods. We have nutritional labels on foods. Why can't we have it, given that unless drugs produce more benefit than harm that patients value, patients may not even want to take the drugs. And then the other thing that complicates this whole thing is the issue of privacy security. And I know that several of you in this room are working on privacy and security. People feel that no one should use a patient's information subsequently without the patient's permission. We also feel that every patient in the community should get the information they need to provide informed consent. If patients say, you can't use my information to tell other people how well or poorly I did when I had a particular treatment, then you can't capture the aggregate information you need to be able to give people the information they need in order to decide whether to accept the treatment or not. So another $9 billion. So what are we going to get from it? Is there going to be better management? Will we have better access? What kind of better access? Has there been any form of testable estimate of the benefits we'll get from this additional expenditure? How many more people will be better or worse? Since we don't know how many people are better or worse now, and we know that 1 in 13 people is harmed, will the harms from the additional expenditure outweigh the benefits? Are we more likely to get people who otherwise wouldn't be treated, getting treated and subject to the harms of a healthcare system? Or will we have more benefit? The British Medical Journal made the comment. They said the one thing we know definitely about prostate-specific antigen screening is that it's harmful. We know that routine colonoscopies for people over 50 years old who don't have risk factors are harmful because you end up with perforations and complications that are avoidable. There's been some discussion around breast screening in young women. Is it valuable? And we know that antidepressants, at least in adolescents and probably in adults, are associated with worsening mood and an increased thinking about depression rather than a decrease. Operating in the Dark spoke about the lack of regular and reliable information. So really what this is about, measuring outcomes, is about how do we reduce superfluous activity? How do we identify all of the bad outcomes so that we can avoid them, not only the ones that come from error? And I guess the other question that we need to ask is, as we put more money into healthcare, we're saying we want more people in health occupations. When I came on the plane yesterday, I sat next to somebody who had just finished a degree in computer science. His interest is in software engineering. He said that all of his friends who were in health, nurses, pharmacists, and so on, had jobs. He said that in computer science, for his graduating class at least, and I suspect it won't be true for this one, I hope it isn't, that people were having difficulty. So as governments pour more and more money into one segment of the economy, they're taking money out of other segments. And then the question is, of course, how can technology help? So what we've sort of said is that if people decide how we spend money, that really information might be the road to peace. That with all the kerfuffle and all the controversy and all the discussion about how to manage a health system, that the only way to resolve the disputes and the disagreement and to choose between the various ideas is to have information about what activities are beneficial and what are harmful. So thanks for taking the time on this day that became sunny. You don't have a whole lot of sunny days. So thank you. If there are any questions...